First of all, thank you very much for having this interview with you, Dr. Sandra Swain. Please tell us a few words about the center you are.
Hello, I'm Dr. Sandra Swain, and I'm at Georgetown University in Washington, D.C., and I'm a breast cancer medical oncologist. I've been treating and researching breast cancer for about 40 years.
So we have a lot of experience in the let's say evolution of this type of cancer.
It is really amazing to me because I started at a time when every woman had a mastectomy. There was no question, and it's changed remarkably during these 40 years in so many ways. Now a woman doesn't have to have mastectomy. In fact, you can't even tell frequently that a woman has had breast cancer because the surgery is just so non-invasive. And then we also have worked a lot on getting the right treatment for the right patient instead of everybody just having the same thing. So we've learned so much about the biology too, about each individual cancer, and we can really tailor the treatment to that patient instead of, just one size fits all and everybody gets the same thing.
Yes, and also the fact that genes responsible were discovered. You can now tailor even deeper these things. But in terms of what have changed during all these years, would you point something especially in the way that the diagnosis is set up, in the way that treatments are run, in the way that women are receiving the news that there is a breast cancer?
Well, there have been a lot of changes. For example, in diagnosis, the mammograms have gotten a lot better, so we can pick up early breast cancer. And we know that the earlier you pick it up, the better the patient can do with it. So that's one advance. I already mentioned there's less surgery, so it's not disforming the patient, and the look is like a natural breast essentially. If a woman has to have a mastectomy, then there's reconstruction. That's also really been advanced over the last, I'd say, 20 years or so. And then as far as the treatment, we have found genes and different what we call gene profiles in the cancer that can tell us what kind of treatment to give. First of all, we look at things like the estrogen receptor, and that's a protein that shows that the tumor is can be affected by hormones in the body. And then we look at things like what we call HER2. It's a gene that makes the cancer very aggressive. So we can compartmentalize the different types of cancer and then give different types of treatment for those different genes and proteins. Then we have our gene profiles that look at a lot of different genes and really help us and tell us which patients may need chemotherapy and which may not need chemotherapy.
But chemotherapy stays there. You cannot exclude chemotherapy.
No, that's not true. I'd say in postmenopausal women, about 75 or 80% don't need chemotherapy if they have early stage disease. That has been really a remarkable achievement, especially in the last few years in the large studies we've done. By looking at genes in the tumor, we can tell that the woman doesn't need chemotherapy, that they just need hormone therapy or endocrine therapy. In premenopausal women, it's more likely that they would get chemotherapy, but it's still not 100%. Still, most of premenopausal women who have ER positive tumors also don't need chemotherapy. So it's a very personalized approach.
Yes, this personalized approach is very, very important because each person is unique, is different, and the response may differ from one person to another. Now, speaking about the impact and the way women are receiving the news, what have changed? Are women less, pessimistic than before? I think so.
I don't think they're less pessimistic. I think it's talked about so much in the media and everywhere about breast cancer, and it's so common. As you get older, it's 1 in 8 women, in the US at least, will get breast cancer. So it's very common, and most women will survive it. So I think, as I said, I've been doing this 40 years. I see much less fear now because everyone seems to know someone who has breast cancer who's done well. Of course, there are patients who don't do well, and that has a bad feeling for someone who has a diagnosis and they know someone who didn't do well. But I think overall, people are very optimistic. I mean, certainly as a physician and as a breast cancer oncologist, I'm extremely optimistic because I see the patients coming back year after year doing so well and living normal lives.
And still, are we, how to say, aware enough, how to say, about the steps we have to take to prevent or to discover a breast cancer in early stages?
Well, I think that the guidelines are there for getting mammography, and I personally recommend it every year after age 40 for sure. If there's family history, you may have to have it earlier and may have to have other tests like MRI. So I think that's really very important.
And how is education? Are women aware that they have to go to check or to do some checks?
I don't know what it's like in Romania, but it's certainly in the US, women are very, very aware of that.
And they come, yes.
And they do come, and it's very high percent of women do get mammograms still.
Okay, that's very encouraging. It means that also, in a way, media is doing well because it spreads the, how to say, the information. Okay, and now let's talk a little bit about the topic you presented at the symposium. So, ovarian suppression in breast cancer, and you focused on a specific study. Give us some details, please.
So I was talking about premenopausal estrogen receptor positive breast cancer, which is still a lot of them in premenopausal. It's about 75%. There are 400,000 premenopausal breast cancer patients in the world, so it's a pretty high number. And what we're doing is a study called the OFSET study, and we're comparing giving these patients chemotherapy with endocrine therapy. And by endocrine therapy, I mean suppressing the ovary with a medication plus giving an aromatase inhibitor, which is an endocrine therapy, versus just doing the ovarian suppression and the aromatase inhibitor to try to see if they really need chemotherapy. We'd really like to get rid of chemotherapy in this group and just use the hormonal therapy, which has less toxicity.
And the results up till now are showing.
Well, we don't have results. We're just starting to accrue in this study. And we're using the Oncotype DX recurrence score, which is a gene profile, to try to determine to which patients potentially need chemotherapy. Like there are a large group that we know don't need chemotherapy based on the Oncotype, and they just get endocrine therapy. And then there are another smaller group that are very high risk that get chemotherapy. It's those in the middle that we're just not sure if they need chemotherapy or not. And the guidelines actually suggest that you could either do chemotherapy or hormone therapy. So we're trying to answer that question, do they really need chemotherapy? Because you can have long-term effects from that.
And usually people are asking, okay, when we'll see the results? So
unfortunately, 10 years from now, it's a long time. And the study is based on two very large studies who both took 10 years. And it just takes a long time. The good news in that is that it takes a long time because not many of the patients actually have a recurrence, and most patients survive, and most patients do very well.
Yeah.
So that's very good news. But then it takes longer to try to figure out those few patients who aren't doing as well what they really need.
So this is a very important message. It needs time and also funding for running such studies. So from the, how to say, economical point of view, is there any limitations you see?
For what?
For funding such types
Well,
of studies?
I think the study is incredibly important, and it is funded by the National Cancer Institute and NIH in the U.S. We would love to have other countries join, but it does take funding from different places to do that. This trial is somewhat unique and it doesn't require a specific drug. So it's not a new drug therapy. It's already drugs that are available. So it's not as expensive maybe as some of the newer targeted therapies that are out there.
What would you say is the next important, let's say, important step in cancer, in breast cancer?
I think the biggest gaps are a couple. One is in triple negative breast cancer, which is, I don't like that term actually, because it's really probably a basket of different cancers. It's about 10 or 15% of the breast cancers have no estrogen receptor or HER2 receptor, so we call them triple negative, or progesterone receptor, so triple negative. But within that group, there are a lot of different actors. I mean, some of the cancers are really aggressive, some not so. So I think we really need to define that group better and get better treatments, because if those patients have a recurrence, they don't do well. And it's very different than those with ER positive or HER2 positive. We have very good treatments for both of those, but with this triple negative, it's not so advanced. So that is definitely one area. The other area is in, again, this is not common, but it's occurs enough times, and patients have advanced disease. They get disease in the brain metastasis. So much more work needs to be done in that area. In patients who have, for example, HER2 positive disease and get a brain recurrence, they can do extremely well. I think that's a message that's important. Just because you get something in your brain doesn't mean you're going to die immediately. In fact, I have a patient now who's over, I can't even remember how many years now, 8 or 9 years with the tumor in her brain, and she had HER2 positive disease, and her daughter just got married. I mean, she lives a normal life right now, even though she's got metastatic disease. So I think that's really important, to try to continue to get therapies for different aspects like the brain metastasis.
It's very interesting how these metastatic things are behaving differently. You don't know exactly right now why is this happening.
We don't, and that's why all the biologists and the basic scientists are working very hard to look at those things. What causes the cancers to begin with, what causes resistance to the different treatments, because there's still a lot we need to research.
A lot of work to do.
Yes,
also
a lot of work to do.
And now about this event, this symposium, what is your opinion about the topics discussed here?
Well, I thought the exosome presentations were really interesting. That I didn't know much about that area. Dr. Leiden talked about that a couple of days ago, and I downloaded all the articles, so I'm going to read about it, because I think it's a very interesting area to try to figure out, again, better targets for treatment. A lot of our treatments are very non-specific. The chemotherapies affect all cells, even normal cells.
Yes.
So to try, and some of the work that they looked at was trying to figure out why the cancer cells go and grow in different areas like the liver or the lung. So I thought that was really interesting.
What about immunotherapies?
Immunotherapies are, I'd say, okay for breast cancer. They're not a home run. They do work in triple negative breast cancer in a percent of patients, and have been beneficial, but in ER positive, they have marginal benefit right now.
So, as a conclusion, there is no one solution even for one type of cancer. You have to combine, you have to look in different places.
Well, there's definitely no one solution for breast cancer, because breast cancer is many different diseases, and people are many different people. So
Yes.
your body also metabolizes drugs differently, and how you have different side effects. So I think the whole idea is to look at the whole person and also just to look at the tumor in that person to see what the best treatment is.
And the expectations are from where? From genetics or from genomics or from...
Well, I think not just genetics, because we have a lot of information on that, but it's got to be in proteins, proteomics, and as you know, I mentioned the exosomes, looking at the tumor microenvironment, looking at the immune system, looking at the microbiome, looking at all those things, how they affect tumor growth and treatment.
Okay, so the picture is bigger and wider and more complex.
It keeps getting bigger, which is good.
Yes.
We're learning a lot.
Yes. So thank you very, very much for this talk.
Thank you.